Now we are going to discuss regarding rheumatoid arthritis. So now I am going to start. Rheumatoid arthritis. So rheumatoid arthritis is chronic autoimmune disorder. Primarily it targets joints. So it is characterized by non-suppurative proliferative, non-characterized by non-suppurative proliferative and inflammatory synovitis. Inflammatory synovitis in inflammation of synovitis that leads to cartilage destruction and joint fusion. Like joint is movable, like this is a type of joint, and this is like movement is occurring, but after that there is a destruction of cartilage and a joint fusion that leading to the non-movable joint formation or less movable movement occur. This is this, and this joint fusion is known as ankylosis. In the advanced case, there is joint fusion occur mainly in advanced case. This is main focus on the joint, but there is some extra articular involvement, like extra articular involvement. In extra-articular involvement, some skin lesion is involved by the autoimmune heart, lungs, and vessels. Like what happened in this case? Like there is mimics other autoimmune diseases. Like SLE, scleroderma of types of disease. This disease mimic is like other autoimmune diseases like SLE and scleroderma, and so there is also involvement of the heart, skin, and lungs and vessels. When we look for the epidemiology of this disease, epidemiology. So in the epidemiology, like mainly there is 1% of people which suffer in the USA, and there is mainly peak incidence of like second to fourth decade. It is mainly incidence, like peak incidence onset. And when we look for the ratio of male and female, so female is more prone than male. So when we look for the ratio, there is 3:1. Like female has 3 times more suffer than the male. And now we are going to discuss regarding the pathogenesis of rheumatic arthritis. So it is a revision video. You can look for Robbins. Like it is initiated by the CD4 cell, CD4 and T cells. T cells. It is like when it initiated that autoimmune inflammation occurred in the joints, like autoimmune inflammation, immune inflammations in joint. And then there is like also involvement of like genetic factors, involvement of genetic predisposition and environmental triggers. Like involves like genetic predisposition, genetic predisposition like HLA, DR4. This is linked with ACPA, anti-citrullin peptide, and rheumatoid arthritis. So there is also environmental triggers, trigger like smoking and infections, like infection like periodontitis, periodontitis, like infection lead to this rheumatic arthritis. When you look for the keys, some involvement of cytokines, like there is like source, there is some cell like T helper 1 cell, T helper 17 cell, and activated T cells, and some macrophages. These cell releases like some cytokines, like T helper 1 cell release INF gamma, T helper 17, interleukin 17 is release interleukin 17, and activated T cells releases Rankel complex, and macrophages release like in TNF and interleukin 1. These cytokines have some roles on some function. So this INF gamma activate macrophage and synovial cells. When macrophages activated, that release, like when we look in the it's activated macrophages and macrophages release TNF and interleukin 1. When interleukin 17 release that recurrent, it helps the recurrent neutrophil and monocytes in their location. Recurrent neutrophils and monocyte and the inflammation location. And when activated T cells release Rankel, then it's promote bone resorptions. And activated macrophages. When macrophage activates, that secrete in TNF and interleukin 1. This help to the stimulate cartilage degrading enzymes. So there is like this TNF is a central mediator, and which is triggered by anti-TNF biologies, like triggered by anti-TNF biological agents. Biologics. There is some formation of autoantibody. like auto antibodies and auto antibodies like anti citrulline citrulinated peptide antibody bodies ACPAS antibodies, and another one is rheumatic factor, rheumatoid factors RF. Regarding anti-citrulinated peptide antibody, it is against citrulline protein against citrulinated protein. For example, fibrinogen, collagen 2, and vimentin. These are the some protein which are called citrulinated protein, and it's against them there is formation of antibody. It is like 70% of rheumatic arthritis patients presence. And diagnostic, it helps to the diagnosis of the possibly pathogenic diagnostic positive. Regarding rheumatic factor, in the rheumatic factor, rheumatoid factor, there is IgG, IgM, and IgG antibody. IgG against IgG FC receptor, and it is present 18%, but not a specific. Like in the image view, when we look for the pathogenesis, there is susceptibility gene of HLA and other, like susceptibility gene of others, HLA and other reason, or environmental factor, infection and smoking. Like smoking stimulates the citrulline proteins, like enzymatic modification. Enzymatic modification and citrullation of the cell protein. Then it is and susceptible gene HLA and others also failure of tolerance of unregulated lymphocyte activation. There is intolerance. There is failure of the tolerance that leads to the intolerance and that unregulated lymphocyte activation occur. And when the lymphocyte activate and there is a certain proteination is form more, then there is the activation of the T cell and B cell response against the self antigen, and that including antigen in the joint tissue, So there is the T helper 17 cell and T helper 1 cell and antibody formation, and that lead to the lymphocyte, antibody, and immune complex enter into joint. These all are joint into complexes enter into joint, and that lead to the release of proteases and the cytokines. And also these stimulate fibroblast, chondrocytes, and the synovial cells to proliferate, and these cells also release proteases and cytokines that stimulate and fibroblast activation, chondrocytes and synovial cells activation of the pannus formation occur, and there is a destruction of bone and cartilage occur. Pannus formation and destruction of bone due to the release of proteins and cytokines, and proliferation of these cells lead to the activation and lead to the destruction of this bone and cartilage. So now we are moving to the morphology. In the morphology portion, affected joints, mainly there is a small joints are affected, like a small affected small joints like hand and feet joints, feet. Like there is a gross change. When we look for the gross change. In the gross change, there is thickened. There is thickened edematous synovium. That's this form villi. There is also histological features. Like one look for the histological or microscopic. So there is like occurring of different type of the 2, 3, 4, 5. So first there is synovial hyperplasia, and then there is dense lymphocytic infiltration, like which cell? CD4 cell and T cell, B cell, and plasma infiltration occur. And there is also angiogenesis occurring by the vascularity. Angiogenesis, increase vascularity. Then there is fibrin exudate in the joint space. There is deposition like fibrin exudate inside in joint space. Occurring space. Then there is like venous formation. Occur. Venous formation means like there is inflamed granulation tissue that's invades and destroy the cartilage. Then invade and destroys cartilage, and then there is formation of fibrous, and then occur bony ankylosis. There is like normal joint. There is a synovial membrane and cartilage, and when in the rheumatoid joints there is infiltration of macrophage, plasma cell, and dendritic cells and lymphocyte, and there is neutrophils and immune complex against this. And there is the formation of the venous. These all are leading to the formation of venous. This is venous formation. So this happened regarding the histology. So now there is also formation of rheumatoid nodules. There is like some sites where it's sites of the rheumatic nodules, like subcutaneous tissue, tissue lesion, like elbow, occipital, behind the occipital one, occiput and forearms. And when looking for the histology of rheumatoid nodules, there is central fibrosis, central fibrinoid necrosis, and it is surrounded by palisading macrophages, lymphocyte. Like when we look in the diagram, this is the central fibrinoid necrosis, and periphery. There is a palisading in the periphery. There is a palisading macrophages and lymphocytes. We can see in this image, like there is fibrinoid necrosis, central fibrinoid and peripheral, surrounded by the lymphocytic. You can look. This is the histology of rheumatoid nodules. Now we are moving on complications, like other complication. When we look for other complication, there is a leukocytoclastic vasculitis. It means there is the ulcer in the skin ulcer, purpura, and nail bed infarct formation. And when you look for the ocular, it is another is ocular. In ocular, there is uveitis, keratoconjunctivitis, like surgeon Jogren, there is some clinical features, like when we discuss like clinical features. Now we are moving on clinical features. Like there is general symptoms, like it's divided as general symptoms, and joint involvement. Like in general symptoms, there is muscle pain, malaise, fatigue, and musculoskeletal pain, skeletal pain. And there is like some joint symptoms follow week to month. Joint symptoms like week to month. When we go for joint involvement, like there is symmetrical progression in the joint. Progression arthritis, symmetrical progression arthritis, and it start from small joints like or thin and large, small joint and thin and large. Mainly affected joints are like in hand, feet, wrist, wrist, ankle, and elbow and knee, elbow, knee, knees. So when you look for the in the hand, there is the metacarpal and metacarpal phalangeal joint is involved, and other is the phalangeal interphalangeal joints are involved. And these are but when we look for the rheumatic arthritis, there is the rheumatic arthritis. There is distal interphalangeal joint are involved, but here is the proximal phalangeal joint are involved. Proximal phalangeal joint, it's involved in the osteoarthritis. Now there is the joint symptoms, like joint symptoms. When we look for the joint symptoms, there is in the joints there is swollen, warm, and tender joint, and there is morning stiffness, more than 1 hour. It does not improve with activity and doesn't improve with activity. And when we look to range of motion, there is decreased range of motion and increased progressive deformities occur. And like when we look for deformities type, when we look for deformities, there is radial deviation at the wrist, ulnar deviation in fingers, and swan neck deformities. There is swan neck deformities, like there is the proximal interphalangeal joint hyperextension, and there is distal. In this, there is distal interphalangeal is flexion, and another is the Boutonary deformities. Like there is PIP is flexion and DIP is opposite of this. This is regarding some morphology, and now in coming videos we discuss more.